So the RETAIN trial was designed to see if we can select patients with muscle-invasive bladder cancer who normally go on to surgery to remove their bladder with neoadjuvant chemotherapy typically, but not always, or who get chemoradiation, if we can identify patients who can be spared both. In other words, patients who could retain, hence the name of the trial, their bladder, keep their bladder in place, um, and yet be treated and hopefully cured for muscle-invasive bladder cancer. So it's really a paradigm shift in trying to find a new way to improve quality of life, but preserve long-term outcomes for these patients. And so that was the big idea of the trial. Right. So this was a sort of single arm trial, and approximately 70 patients were enrolled. And what we did is we initiated with molecular profiling of their tumor, of their TURBT initial sample. And what we were looking for were DNA damage repair mutations. And the reasons we were looking for that is that in prior work from our group and from others, we've shown that patients who have a DNA damage repair mutation are much more sensitive to cisplatin neoadjuvant chemotherapy and have really excellent PT0 results. In other words, showing no evidence of bladder tumor at the time of surgery and have excellent long-term outcomes. And so we thought that if we included patients who have one of those mutations and who then have a clinically complete response after neoadjuvant chemotherapy is assessed by second TURBT, we could select those patients and allow them to go on to active surveillance. And so that was one of the groups. And then all other patients who do not have a mutation or who have still some evidence of residual disease, they go on to receive some sort of therapy, either intravesical therapy for those who have non-muscle invasive disease, radiation, or surgery. And so the study was run at 4 sites. It was accrued over a couple of years from approximately 2016 to 2018. And then we had long-term follow-up for those patients. So this is one of the key questions. As I mentioned, we thought that we could better identify patients for active surveillance by looking at their mutational profile. And if they have one of these DNA damage repair mutations, that they would be therefore more susceptible to cisplatin-based chemotherapy and therefore more likely to be free of disease afterwards and hence be the more favorable patient to go on to active surveillance. And so we chose ERCC2, ATM, RB1, and FANC as the 4 mutations. And what we actually ended up finding is that there was no clear association between better outcomes or lack of recurrence for patients on active surveillance based on their mutations. It did not seem that the mutations, in other words, helped us to better select patients in addition to the clinical factors that we were using. And this has been supported in another trial that was recently published. It is still being looked on in a big cooperative group trial, although with a different set of DNA damage repair mutation, a larger set. So the question isn't fully settled, but it appears that it probably are not the biomarkers that we need for this kind of bladder preservation approach. And probably what's more important is improving the systemic therapy we give. Considering adjuvant therapy, not just neoadjuvant like we did, and also looking for other clinical factors like MRI imaging and really good mapping TURBTs to decide who should go on to active surveillance, not necessarily the genomic markers. And then finally, of course, ctDNA and urinary markers will really be very important. We did not use that in a prospective manner to select the patients.